people who present with trigger finger are looking at their A1Cs, and almost 100% of the time their A1C is deranged. You don't go to the doctor to look at their, no one says, oh, my A1C feels off, right? But they say my finger's not working. Often I'm the person that people see when they don't want to have surgery. So they're saying, what can I do to avoid that? And sometimes it's inevitable, but sometimes it's like, okay, well, if you really don't want a knee replacement within the next year, then here's the things you have to do. It's like, well, first of all, it's better to be moving than not moving. I'm always telling people that, every pound on your body is 4 times as much pressure on your knees. So you might want to think about that. Even a small weight loss can have a 4 times magnitude reduction in stress on your knee joints. I spend a lot of my time talking about butts, actually. So especially for women.
Today with us, we have Dr. Amy West, who is joining us from, where the heck were you?
New York.
Pennsylvania, somewhere east.
New York, yeah.
From New York.
Mm-hmm.
I've met Amy a couple times now at conferences, and she actually came into the house. We had a steak together back a few months ago.
Oh, yeah.
Amy, I guess for those who don't know you, tell us your background.
I am a sports medicine physician, non-operative sports medicine physician in physical medicine and rehabilitation. I work in New York. I went to Harvard Medical School, did my residency, Harvard, PM&R. I'm a lifelong athlete. I'm a CrossFitter. I'm a competitive CrossFit athlete, Olympic weightlifter. So I'm super involved in fitness and all things related to metabolic health, fitness, and how that interacts with sports medicine, orthopedic world. I've been talking about that stuff for a long time. So yeah, so that's sort of me in short.
Yeah, me too. I've been talking about that stuff for quite a while now. But many people are unfamiliar with the specialty physical medicine and rehab. Can you maybe just give an overview of what that entails?
Yeah, so we're the best kept secret in medicine as far as I'm concerned. But physical medicine, rehabilitation. So we focus on the physical manifestations of disease processes. So how disease affects your body and affects your function. And that's pretty broad. We kind of subspecialize in all different things. I primarily focus on sports injuries, but we also deal with things like traumatic brain injuries and how that affects your function, spinal cord injuries, strokes. So we're not treating the actual issue like a stroke. That's the neurologists do that, but then we deal with how the stroke affects your body and your walking and your spasticity and how you go to the bathroom and all that kind of stuff. Similarly with cancer, we work with cancer rehabilitation. Oncologists take care of the cancer treatment. We take care of how that treatment and how the disease affects how you live your life. And that's the theme in physical medicine rehabilitation. So that always appealed to me in dealing with people's quality of life and their function rather than just attacking the issue with medications and things like that.
Now, there's both outpatient and inpatient. I know when I was doing my orthopedic residency, we did 1 month of PM&R, but it was an inpatient sort of setting. Yeah. And it was interesting. It was nice because there were no real emergencies in that situation. It was pretty non-emergent stuff, so you got a little more sleep. Although we get called to put in IVs and stuff like that in the middle of the night occasionally. But anyway, so you're primarily outpatient, I'm assuming? Yeah,
so I'm all outpatient. So I'm a PM&R physician by training, but I work for an orthopedics department. So I'm essentially kind of part of that department. And because I'm not an orthopedic surgeon, I don't have to say call for them. So I'm in this no man's land of call, which is nice. So I don't do any inpatient work anymore, but it's all outpatient for me.
Obviously, you and I understand that metabolic health impacts more than just diabetes. And that's what we kind of, but I see it manifest in orthopedics and probably damn near every specialty at this point. Let me get your thoughts on health in general. What do we, obviously healthcare has, I think, some holes in there, some blind spots when it comes to metabolic or chronic disease in general. But what has been I know you do a fairly low carb diet. I think you eat a lot of meat like me and stuff like that. You're an athlete, so I mean, I support you. How does it impact the people you deal with, do you think?
Majority of the patients I see have multiple chronic metabolic conditions, almost everybody. And I work in sports medicine. I do see athletes, but that's a small percentage of actual people that I see who have just aches and pains and injuries from other things. The majority of patients I see are actually people who are multiple chronic diseases. They're in and out of the hospital with those things. And for the most part, aren't particularly active or have very misguided understanding of what exercise is or what nutrition is. They've been in the medical system for so long, and they're being told things that up to this point haven't really helped them as far as how to eat and what kind of exercise they should be doing and how often. So often they're confused by all that. And then I see, as far as metabolic and how metabolic issues and orthopedic issues often are going hand in hand. When people will present here with something like a like something like a trigger finger, for example, or adhesive capsulitis, a frozen shoulder. And that's what brings them into the doctor. And then that, looking further into their metabolic health, and it uncovers a whole series of things that have been deranged for a long period of time. There's actually a research study going on here now where they're looking at people who present with trigger finger and looking at their A1Cs, and almost 100% of the time their A1C is deranged. Yeah. And they wouldn't have known that because they don't go to the doctor to look at no one says, oh, my A1C feels off, right? But they say my finger's not working. So let's want to get that checked out. Often these things are harbingers of much bigger problems, and we're catching them in the orthopedic space first. That's something that's definitely been popping up quite a bit. And then on the other end of that...
No, go ahead. I was
saying, another thing I see quite often. So I've been doing CrossFit for a long time. I have a lot of friends in the CrossFit community. I work at the CrossFit Games as part of their medical team there. And as a result, I see a lot of local people who are CrossFitters, own gyms, et cetera. And they'll come in with issues, longstanding aches and pains. And I'll see that, for example, I have one lady who owns a gym. She's CrossFitting. She's in her 50s. She had some trauma to her shoulder a long time ago. Never really thought much of it. And she's like, yeah, it hurts a little bit when I do some pull-ups. And I saw her x-ray, and like her joint was just demolished. There was no cartilage left in there, osteophytes, like bone spurs, and it was mangled. And in other people with that underlying pathology, they can barely move. Whereas she was like, yeah, my pull-ups aren't what they used to be. And I see that time and time again with especially older people who have been active, who are swimmers, runners, et cetera. The amount of pain that they're having is so much less compared to someone with minor changes on their x-ray who can barely move. And what's the differentiator? It's essentially their metabolic health and their physical activity.
Yeah, I can remember when I was doing my residency, our foot and ankle director, he said he could literally diagnose diabetes by examining the stiffness in their Achilles, because we have this change in some of the tissue quality, as you probably are quite aware.
Yeah.
One of the things that even as an orthopedic surgeon, I never learned this, or at least wasn't emphasized in any of my training. It's not really particularly emphasized in any book unless you really look for it, was perioperative nutrition. Was just, you don't want somebody to have a really low albumin and they're like sick and cachexic. But outside of that, the literature seems to support higher protein intakes in and around trauma, surgeries, recovery, healing. Is that something that you get involved with? And is it like, hey, you need to improve your protein quality content while people are healing?
Yeah, so I do see that a fair amount. I often am the person that people see when they don't want to have surgery. So they're saying, what can I do to avoid that? And sometimes it's inevitable, but sometimes it's okay. If you really don't want a knee replacement within the next year, then here's the things you have to do. And it's fixing your nutrition, it's losing weight. And there's injections and stuff that I can do to help with that. But a lot of this is you have to optimize everything else. There's a lot of people who need to lose weight. And then they go, how do I go about doing that? And then, let's talk about protein intake, things like that. And I go, even if you end up having the surgery, you'll recover faster. You'll do better on the back end of it. So a lot of that talk is either leading up to surgery or trying to prevent it, or at least making that process easier on the back end.
Yeah, I can remember when I started putting patients on low-carb diets and I had them in the hospital and post-op day 1 knee surgery. And this is back in the day, we keep them for a day or two. Now a lot of it's outpatient. But I was just remarkably impressed at how little pain they had on post-op day 1 relative to other people. It just seems like the inflammation was tamped down, which obviously that's a good thing, because then when it comes to mobility and just better quality of experience. So what about, let's talk about the role of strength training in health of the joints, preventing injury, and even in a compromised joint. Yeah. Because a lot of people are like, oh my God, I hurt my knee. I have to lay off it all the time. I can never use it again. Mm-hmm. What are your thoughts around those things?
Oh yeah. So that's a conversation I have quite frequently. People saying, oh, I have this named the thing, so therefore I should just do nothing. Or should I exercise, or should I strength train? And it's like, first of all, it's better to be moving than not moving. I'm always telling people that. Yes, if you do nothing, yes, maybe you won't make that meniscus tear bigger, but you're going to cause yourself a whole bunch of other problems by not moving. All the other benefits of exercise that you're losing. Not to mention building up the strength around the joint, improving the functional movement of the joint, the movement patterns of your body. These will only help the situation, to help with your pain, help with the function, help with the strength around the joint. So something that I have to combat that idea quite often is if I've hurt myself, therefore I shouldn't do anything because I might make it worse. You will definitely make it worse by doing nothing. So you'll make your health worse by doing nothing. So you have to get moving.
Yeah, I cannot tell you how many sedentary patients I did knee replacements on. And it's a lot of that is we're coming to find out that even though there is this wear and tear mechanical loading component to joint wear, there's a big biological component, and having all this extra obesity with inflammatory cytokines, high insulin levels seems to contribute to that. And the other thing that a lot of people, when we talk about joint stability, like for the shoulder's a great example because it's our least stable joint generally because it's got such a large degree of range of motion or freedom of motion. And it's a joint structure, it's the ligaments, but also the muscle plays a role in dynamic stability. And so when you have, I talk to people, it's like driving your car with tires that are out of balance. Eventually they're going to wear a lot quicker so that the muscles just hold things in a position they're supposed to be in. Do you ever give nutrition advice to your patients? Is that something you're comfortable doing, allowed to do? Well, in a physician, you should be able to.
So it's a little bit of a tricky situation. So yes, I do. I tend to just focus on like protein goals because I feel like that's a very kind of clear cut thing. I can really say, try to hit this. If you're hitting that, then we can distill down into further advice. But so in general, in my regular clinic practice, and I can see 40 people in a day, it's fairly quick visits. And most of the people that I see in general are frankly not interested in a lot of that. It's like, hey, I have this pain, fix me. I gotta get going kind of thing. So in those situations, that's how I deal with that. But when people express interest or ask me, I'm more than happy to talk about it and give them advice. And I will talk to them more in depth about it. It's funny especially working in big health systems like this, is if someone can be 300 pounds and if you say something about, oh, hey, you need to lose weight, regardless of whether you're right, how you say it, how it's introduced, the patient here is, the doctor called me fat, and they'll write a review of you online and you'll get in trouble for it. You have to be very careful with like how those conversations come up. People express an interest to me or say, I know I need to lose weight, and then XYZ. Then I attack it from that perspective, saying, hey, every pound on your body is 4 times as much pressure on your knees. So you might want to think about that. Even a small weight loss can have a 4 times magnitude reduction in stress on your knee joints. So that's really important. And people said that will stick with people. They'll take that, and then we could get it more into the nutrition stuff. So I do some like online education through a company called Best in Class MD. So people really want me to break down and go into the weeds with their nutrition and like exercise plans. And I have like more time to do that there. But like my everyday practice, it's more like people ask, I'll tell them, and I'll give them some guidelines. How many people actually are interested and will stick to it?
It's probably difficult when probably a majority of the patients would benefit from better nutrition.
Everybody, really.
It was like biting your tongue. I remember when I started doing this, and I thought I was just going to hand out flyers to a certain selected number of people. And then all of a sudden I was handing out 30 and 40 a day in my clinic. I was like, all these people need this stuff. It was just crazy.
Yeah.
I used to do this kind of crazy. When I had people come with carpal tunnel syndrome, I had this thought that I think carpal tunnel is probably a metabolic downstream effect. And I was testing insulin levels. Yeah. And I got some really weird calls from the lab. Like, why are you testing insulin?
Yeah.
Yeah. I got and they were high. It was unsurprising. They were high. What about, you mentioned protein goals. What are the protein goals for in your population? And does it matter like injury versus, how do you determine that?
I usually will just say a gram per pound of lean body weight, ideal body weight. So in general, I'm telling people like most women say like around like 140 grams a day, roughly, and just trying to hit that, or trying to get a decent amount of protein per meal, like making that the priority of the meal. So try 5 to 6 ounces of some kind of protein per meal, and just see if you can hit that. If people are mastering that, then we can break it down, get into the weeds with specifics and goals and stuff like that. Most people, especially women, not coming anywhere close. I was talking at a women's health symposium not that long ago, and it was like a breakfast thing. Had a big breakfast buffet out, and I just looked at it and I said, look at everything on that table. There is no good source of protein on that whole entire table. It's all muffins and Danishes and other just crap that was on that table. And I said, there is nothing there of any nutritional value. Health symposium. So let's start there. Let's break that down. And everyone was like genuinely surprised. They really were like, oh, wow, they had no idea. So I think just like breaking that down first is like the first step.
Yeah, if it's a bran muffin, though.
Yeah, right.
It's like, yeah, right. All these damn muffins. Yeah. That's a medical conference. They always have garbage food.
Yeah,
Let me talk a little bit about your athletic stuff. Yeah. So you said you went to, I think you said you went to Harvard, and what kind of athletics have you done throughout your life?
Oh, I played everything as a kid. I was into all kinds of things, but I ended up playing semi-professional softball in Europe for a period of time after college. So I was doing that. And then ultimately when I got into med school, you hit this point, like in your adult life, you're playing team sports your whole life, and then it stops, and you're like, what should I do? I guess I'll start running, which I wasn't like a huge fan of. And then I stumbled upon a CrossFit gym while I was in med school, and then that was it for me. So I've been doing that and competitively over the past 12 years. And then as a result of that, started Olympic weightlifting. So I compete in that as well, giving me a nice sort of second chance at being somewhat of a competitive athlete.
Yeah, it's particularly as you get older. I'm almost 60 now. There's not a lot of team sports where anybody's taking anything any seriously.
Right.
And you worry about, are the people going to break? I can remember when I was doing jiu-jitsu, I would mostly go against younger guys because every time I went against an older guy my age, I thought I was going to hurt him.
Right.
It's like everybody's so frail. So
yeah, and also I played in some recreational sports leagues in the area, and all of their women's leagues, and all the women, for the most part, that were my age were either too injured or overweight and just couldn't physically do it. So then I was like, I'm playing with a bunch of 20-year-olds. I should have something else to do. But yeah, so it's not uncommon, unfortunately.
Yeah, for sure. So what about, the orthopedic group that you work with, I'm sure they do a lot of joint replacements and trauma and all the stuff that I'm sure you end up with. How on board are they? Because I was fairly progressive when it came to like post-op rehab. I had my total joints. I told them, fine, go lift weights. Yeah. And I thought that was healthy for them. Is that generally the thought now? Obviously, they've employed you. I'm sure that's the message you're trying to send out there, or no?
It's all over. So I work for the biggest health system in New York. So we have a ton of orthopedic surgeons. I don't even know all of them. There's so many. I am one of 3 non-operative people in the department, and only one of 2 PM&R doctors in it. When I was hired, they actually didn't know that PM&R doctors did sports medicine. They were like, oh, wow, that's interesting. So I got brought on. I was like a new thing to the system when I came in here. But yeah, they range as far as what they're prescribing, what they tell each other. There's some surgeons that are more lenient than others. There's some more focused on certain things than others. I see people from all over.
What, as far as like things that you find that are, obviously there's strengthening and range of motion stuff and nutrition, but I know there's a lot of different modalities out there. Some have come and gone. Some have been somewhat useful. Some of them kind of a waste of time. Yeah. What do you find is actually useful in your practice?
Yeah. As far as the things I'm doing here, we've started doing some orthobiologics as far as for different pathologies like tendinopathies and mild to moderate cases of OA, things like PRP, platelet-rich plasma, which has some promising results if in the right patient population, the right injury, the right setting. I think there are a lot of people pushing it for everything when it's not going to work, and then that causes some kind of bad things or just waste people's money. But so different kind of orthobiologics, extracorporeal shockwave treatment, something that has had some promising results as well. So dabbling in those things.
That was primarily using, it's like lithotripsy they did. I know that was one of the initial places for breaking up kidney stones. But my thought around whether it's PRP or stem cells or some of these now peptides that people are using is that if I liken it to recarpeting my house, and if my house is on fire, it's not a very good time to put new carpets in. Right. So put out the fire. So I think if you can fix some metabolic damage, it's going to have at least better chance of being efficacious. So I know, I think last I looked at the Orthopedic Academy's position paper on things like stem cells and PRP, they were like kind of meh. There's not a lot of strong evidence. We can't strongly recommend it. Who knows? And obviously there's champions that their whole clinic is based on that. And so they see
it's also not very standardized right now as far as when you say PRP, like different places are using different concentrations and different protocols. And so that's something that needs to be hammered out a little bit more clearly.
Yeah, and when you say it didn't work, you didn't do the right formulation. I hear that all the time. It's all, I don't know. Maybe you should have stopped eating cupcakes and pizza before you went and did it.
The same thing with peptides. I mean, I think there's some really interesting things that may help, but you got to fix all the underlying stuff first, because that's like a drop in the bucket.
So the CrossFit stuff. So let me ask you this, because obviously CrossFit there's a lot of detractors. I think it's pretty cool. I think I thought about doing it for a while, but then it was during COVID and it got shut down. I was like, I don't want to stand around in a mask and do it from home. And it just, so I ended up I went to do jiu-jitsu instead. But, and as you see me, I'm tall. I'm not the ideal CrossFit athlete. I'm tall. I don't know. Too heavy.
You're strong enough, man.
Strong, yeah. There's some things I could do, like a deadlift. I could probably do good wall balls and stuff, but some of the hands gymnastic stuff I'd struggle with. But let me ask you, as a CrossFit athlete, who I presume, and correct me if I'm wrong, you're on a fairly low carb diet. How does that work for you?
Yeah, I do eat carbs around my training, and I've thus far have not had any issues as far as running into issues, problems with my training as a result of restricting that in any way. Like I said, I'm maybe around, depending on the day, about between 80 grams of carbs a day, maybe. And like I said, I haven't had many issues with that. It works for me. Everybody's different. Everyone has their own needs and things that work for them. But and there are some people, and certainly in the CrossFit community, saying we should be eating way more than that. And for some people, they need that, and it works better for them. For me, it's like I've gotten used to it at this point. So
yeah. Yeah. I presented in front of one of the large strength coaches meeting back a few months ago in South Carolina, something called Summer Strong's puts on. It's got a lot of top collegiate strength coaches and some of the NFL guys. And basically the conclusion, I think, is whatever you're chronically adapted to. And if you're chronically adapted to a low carb diet, you can do pretty damn well with that. Your body, and it may take a while. It may take many months and even years, I think, in some cases to really be, and that's what the literature seems to support. The scan amount that's out there, there's very little literature that looks at long-term adaptations around this stuff. But how do you, because I think you said you're doing Olympic lifting as well. Obviously, CrossFit's the introduction to Olympic lifting for a lot of people. It's part of their programming. I assume you gravitate toward that because you're fairly good at it.
I'm part of Olympic. I've always been strong. I was like, your girl was just strong, but I didn't really know much how to channel that. And then with the Olympic weightlifting, because it's so technical, in CrossFit, you do it. And if you want to go, I plateaued with the weights I was able to do. And I said, if I could just figure out how to do this technically better, then maybe I can start breaking that plateau. So that's how I got into it. There's a weightlifting coach at Jimmy. Hey, you're strong, but you need to work with me and I'll have you lift them more. And I said, okay, challenge accepted. So that's how I got into it. I still have a lot. It's a thing you feel like you never have a handle on, honestly. So I'm still figuring it out, but it's a way to channel my strength into a more productive way.
Yeah, I use the Olympic lifts for like when I was throwing, but I never technically got good. In fact, I'm technically fairly horrible at it. I'm just strong, so I can just bull the things. I did a lot of power movements and not very deep catches and ugly. For me, I just assume do high pulls and stuff like that in many cases. And just because I don't need to catch it, I'm not competing. Whereas CrossFit, you might be, and certainly Olympic lifting, you have to be. So but they're good exercises.
Yeah, it has to be so technically sound, but also like you have to be able to. I think a lot of people chill out CrossFit and say, oh, like, why Olympic lifting? Like, why does a grandma need to know how to do that? And it's not necessarily the lift, but it's training those neuromuscular patterns to move something a certain way. That's actually really important to harness. And if your grandma can snatch a PVC pipe, I'm much less worried about her falling. She's already demonstrated the motor control to do that. So like training those patterns, even if you end up not really lifting all that much, can actually be really valuable.
Yeah, that is something. I'm playing with a lot of plyometric training right now. And it's one of those things where I think it has such a tremendous utility in older population. If you start you start up really early, but even 50s and 60s, I think if you can jump, like I saw a woman 95 jumping rope and looking good, like she had good rhythm. She was getting off her. She's not going to fall down and break her hip. No. I'm pretty confident because she can catch herself and she has the capacity, because I cannot tell you how many little old ladies tripped over their damn cat or their dog in their kitchen, broke their hip, and then their life is basically, or their bones just break.
Disintegrate. Yeah. I'm seeing that. I see that in old people. I see that in young girls too. Their bones are dust. And you have to build that up because they're just getting these stress fractures and stress injuries and things like that.
Yeah, let me go back to the comment you made about, you said women rarely are eating enough protein. What are you seeing? What populations are you seeing that in? Is it older women? Is it all? Because you probably are dealing with a lot of older folks, I imagine, in a PM&R center. But
yeah, it's across the board. I also am a team physician for a lot of the colleges out here. So I'm seeing young female athletes who are coming in with stress injuries. And then that uncovers it's a whole Pandora's box of things of why did that happen. And they're often having menstrual dysfunction. And it all goes back to not eating enough, either intentionally or overtraining, whether intentionally or not, but finding that energy balance so that they're not having the hormonal derangements and the subsequent bone stress injuries. But I see it across the board, especially with the college kids. They're eating all kind of whatever's in the cafeteria, whatever their friends are giving them, whatever garbage is around, and they don't think twice about it. And then you're seeing the manifestations of that in older people, but either they just don't eat very much, or they have no sense of like how much protein they're not getting, or they're taking those shakes, those like Ensure things or whatever, which are like all seed oils and sugar with protein in it, and that's not how to do it either. So I'd say a majority of the people I see who are just not eating enough and don't realize it really.
Yeah, and protein has been vilified for so long, just for various reasons. So I know some people are coming around to this and figuring it out, but there's still a pretty anti-protein sentiment in many places, I think.
Yeah.
Do you find that when you are able to, how much long-term follow-up do you get on your patients? Because I assume do you get to see people over a period of a year and stuff like that?
Yeah, I have people I see every 3 months, and then that's over. I'll see them for their knee this week, and the next week it's their shoulder. The week after that, it's their back. So I have my regulars that for all their aches and pains. But yeah, no, I see people in general. I tend to see my patients fairly. Yeah. So
do you have like physical therapists, occupational therapists that work in and around with you and under you perhaps?
The health system has affiliated therapy groups. And then in my clinic, I work with an athletic trainer. So she's on site to help with people's like exercise plans and things like in the clinic. And then I also have a network of just people that I've come to know either through CrossFit or through other means that are like local physical therapists or chiropractors and things that I trust, that if someone demonstrates to me that they want to spend the time, the money, the energy, the effort in fixing something, I go, great, I got the perfect guy for you. Really, he'll get it done. And if someone's mad, I guess it's that they don't really want that, then here we have the kind of insurance-based PTs that will do what they do, and they'll help you too.
Yeah. In your office, in your clinic, is there exercise going on in there, or are you coming in doing inject? What is your environment?
So for me, it's like I'm mostly I do shorter consults, and we do a lot of injections here, ultrasound guided injections. So that's a big part of my day. And then I'm assessing. We have x-ray here. People have x-rays, then I'll do my assessment of them. And then in certain cases, people are like, hey, you need some gluteal strengthening. And I have my athletic trainer go in and show them some exercises in the visit. Or sometimes people will ask me, I do get a fair amount of people asking me, here, this is stuff I do at the gym. What can I do? What can I do? And I can break that down for them somewhat briefly here. But I do have an athletic trainer who demonstrates exercises too when we need that.
So are you like completely referral based, or do people come see you as a primary intervention? Or do you usually get referred to from?
I'll have people like in the gym over here, but, hey, I hurt myself. Can I come see you? And, yeah, sure. Or like someone will send them in from that, or there's like a central other primary care doctor send them in, or other orthopedic people will send them in based on what they need, or people who know that I do a lot of like things involved with like exercise and strength training and stuff. You should see her. I see that, and I do separate kind of educational, more in-depth consults through a separate kind of entity.
Okay. And what are, just in the general population, probably so much, but obviously your orthopedic patients are going to be a little different. Yeah. What are some of the major things, interventions you typically see with these are the deficiencies that most people have? I'm sure there's many, but what are some of the common things that you see? Postural, weakness, I don't know what it could be. But
a lot of postural stuff, like shoulder, because everyone's like phones, computers, everyone's like this all day. Right. So then everyone's getting like neck, back pain, shoulder pain from being like this all day. So I see a fair amount of that. I see a fair amount of arthritis, but like pain burden from arthritis. It's not just I have arthritis and it hurts. It's like the pain is almost a little bit out of proportion, or like the amount of function that's being impacted is just a little bit out of proportion to the actual what I'm seeing on the x-rays. And a lot of that has to do with the metabolic state that they're in. A lot of chronic tendinopathies from just chronic inflammation, or like mucinous changes and like ligaments. I actually a fair amount of like people with ACLs that are just falling apart from just years of just not taking care of themselves, frankly. Gout, I see a lot of gout. a lot of gout. It's alarming, actually. And almost always I'll say the people who present with gout are also presenting with some, I'll say cognitive issues as well, which I think there's definitely a link there between the inflammatory process and the nutrition and cognition. And I think I'm just anecdotally, I'm saying there's definitely something here, but I see a fair amount of gout. People will go to the emergency room and say, my knee hurts. And they'll say, okay, it's probably orthopedic. And they send them to me ultimately. And it's, you're chronically inflamed. You're riddled with gout. And they'll tell me what they ate the day before. And I'm like, oh boy, this isn't good. So yeah, I see a fair amount of that. Another like rheumatologic conditions that present, people think it's a structural problem, but it's actually like an inflammatory problem.
Yeah, with gout, when I took care of gout, it almost always seemed to be someone who was also metabolically compromised, either diabetic, pre-diabetic, metabolic. So I think gout it's not just uric acid. I think it's a whole cascade of inflammation, immune system dysfunction. I think there's a whole bunch of things that go in there. And so what I see with my gout people is that when they fix their sort of metabolic state, their gout seems to resolve. Irrespective of what the uric acid level is doing. But yeah, I mean, it's when you see what people are eating, it's because red meat has gotten the blame of gout, and it's probably, you see just as much from fructose and alcohol, and probably more so from those things.
Right.
Honestly, but I think it's more, if you got gout, you'd better check yourself for pre-diabetes and all the other metabolic dysfunction that's going on.
Yeah,
for sure.
And it's crazy because I recognize that, you recognize that, but you'd be surprised how many primary care doctors are not seeing that or not making that connection. They'll just check your gas level and say, and often in an acute flare, the blood level is low. So they'll check the blood level and say, oh, it's fine. You actually don't have gout. I'm like, the story's consistent. The joint aspirate is consistent. It's gout. Trust me. But
well, if the joint aspirate's consistent for sure. Yeah. But it's just, I'll take your allopurinol and whatever.
Right. And that's the list of things. List of things that people are taking. So it's the polypharmacy is conventional.
So do you, as someone who, again, I don't know how the insurance works around this, but if somebody comes in for you to say, hey, I've got knee pain, and you look at them and say, hey, look, there's probably some metabolic issues here, and you would work that up with XYZ laboratory test. Do you ever get a hard time about that? Do you have to go and, ask for pre-authorization because this isn't covered under knee pain and blah, blah, blah?
Oh, it can get pretty tricky. Certainly with a lot of times what I'll do if I really want to do an extensive workup is I'll basically just say, just see your PCP and get these things. Or I'll send a note to the PCP saying, I think they should get these things. Now, how often that actually happens, like the person actually goes and gets a follow-up and it happens, not always. But something like an A1C, for example, like we actually, because of this research that's going on, we're able to get an A1C machine for the office, which took a lot. But because it's under a research project, now we have that ability to try to check it on site. So something like that, we seem to get by with just doing.
I think you touched on like trigger fingers and stuff, and there's clearly a correlation between trigger fingers and diabetes. But what kind of things are you seeing present as orthopedic problems? And you go, hey, I bet your A1C's up. And how often do you find it to be the case? And what are the things you're seeing?
Trigger fingers, chronic tendinopathy. So a lot of these rotator cuff tendinopathies, that if I find someone's they're not an athlete. They're not someone who I would say you should have this kind of all the time. For sure that adhesive capsulitis is another big one. So frozen shoulders, pretty much almost always.
Or like waist tendinopathy, I'm guessing,
all those tendinopathies and thesopathies that are just like these kind of indolent kind of thing. And then certainly like when I see those gout cases, like these inflammatory arthritis looking things that seem to me a little bit off. Anytime I see a mucinous change of a ligament, a lateral epicondylitis, even if someone doesn't have a story that is consistent with a lot of chronic overuse, I'm looking at that. Even some like low back pain people. If I have an MRI and an X-ray that's like doesn't really have a smoking gun on it, I'm saying something else is here. All of those things, and almost always there is a correlation. There's something there. So carpal tunnel, like you were saying, is another one. De Quervain veins is another one. So almost everything I see, all the things I see, because I'm not seeing a lot of like acute traumas. So I'm seeing all these like kind of chronic things, and I'm saying there's something here.
Yeah, I remember one particular diagnosis in orthopod we used to hate seeing was patella tendonitis because it was like, it's not really operative and you can't put camera in there. And it was just a lingering thing. Maybe there's a rehab you would do, but I suspect, because that often presents in younger athletes, I suspect there's probably a metabolic component to that too. I don't know if you see that with patella tendonitis in your younger folks, but I would guess, I don't know.
And the patellar tendonitis, often there's like a lot of patellofemoral issue, which is a lot of like gluteal strengthening and stuff like that. So that's usually the issue is the gluteal strength and just having not a lot of motor control at that area. So I see that more in the younger people.
Let's talk about gluteal strength. That's one of my a topic I enjoy talking about. People don't realize that the reason we can stand upright as humans is because we have these big gluteal muscles. Yeah. That's what they do. They keep us upright. And I think a lot of people, like you see these older people, like particularly old men, and their butt is like a flat, like a pancake. And then you see their walking speed is really low. So talk about the glutes a little bit. How important are they, and how do we effectively keep them robust and strong? And a lot of people like strong glutes. Yes.
I spend a lot of my time talking about butts, actually. So especially for women. But so yeah, your gluteal muscles, they serve many important functions, but especially a lot of the pain syndromes that I see. So they stabilize your hips, stabilizes your low back. It also stabilizes essentially how your femur track. So preventing that kind of valgus moment at the knees. So that can also affect knee pain, people with knee pain, hip pain, back pain. Often it's all at least centrally related to gluteal strength. And a lot of times it's a really simple thing I'll ask people to do is, can you stand on one leg? And you'd be surprised how many people can't do that for any like significant amount, like for 5-10 seconds. And a lot of times people say, I have bad balance. And I'm like, nah. So unless you've had a stroke or you have some kind of like inner ear problem, it's not a balance issue. It's a strength issue. You can't stabilize yourself on one leg without going like this, right? And then if you can do that, can you squat on that leg? Can you do a single leg squat, even if it's half depth? Can you, without your knee tracking in, without your body kind of caving in? And most people cannot do that. And I see fairly strong people too, who are not strong. And then you test their glutes in isolation, their glute medians in particular in isolation, and it's pretty weak. Or even people with really strong legs tend to be quad dominant and their glutes are turned off. Especially like when you think about running, for example, and I see a lot of runners with knee pain, back pain, etc. Like running is a series of single leg squatting. You're landing on one leg and essentially in a sort of a half squat every time. So if your butt isn't strong, it's not holding you up, preventing your hips from tilting, preventing your knees from caving in. Ultimately, imagine you do that thousands of times while you're running. Something's gonna hurt by the time you finish. So I see a lot of that. So in older people who just their butts are disintegrated and turned off, or younger people who aren't really activating them. So we spend a lot of time talking about that here.
What are, for those people that are interested in having a stronger butt, what are some of the more effective things people can do at home, maybe if they don't have a gym membership or something like that?
So squatting, super important. Squatting, making sure while you ascend, you push your knees outward. That's really important. Or anything on one leg, so lunging, or like a split squat. Even if you're doing like a sort of like a pistol single leg squat, but you're lowering yourself to a chair, sitting in the chair and then getting back up instead of that's a way to do it supported, or like tying a band to a pole and holding that while you do it so it pulls you up. But really focusing on that single leg stuff. And like, it should hurt. Like your butt should hurt when you finish. Another thing to test, when I find even clinicians do this incorrectly as far as testing glute strength. So it's not just hip abduction, it's hip abduction and extension and extra rotation of the femur. So if you test somebody's abduction strength and just have them push like laterally out against your hand, most people are pretty strong in that direction. But if you have them push out and then back a little bit, you can break a lot of people that way. So I tell people when they're exercising, if you're doing like clamshells or whatever it is, or kicks, you have to make sure you're kicking out to the side, but also behind you, because that's really important. And also side-to-side movement. So those muscles are really important in your side-to-side movement. And as people, we don't move side-to-side very often. We're always going in this direction, like running, biking, walking. So practice moving laterally, bands on around your legs. You could do that on these monster walks, as they're called, because that could also activate those muscles.
Yeah, fair enough. Interesting. Let me ask you, you're obviously you're practicing, you're doing your CrossFit. I guess you've got some relationships and some other ventures that you're doing. What things are you like planning for the future, if you have anything? Do you think this is what I'd like to do in 5 years? You just keep pressing what you're doing?
There's the day job, which is this stuff, the clinic stuff. But yeah, no, I'm actually working on a book talking about a lot of this stuff with metabolic health and orthopedics, injury and injury prevention. People have been talking about this in other respects. Like Chris Palmer has done an amazing job with the psychiatric piece of this. The orthopedic space is still, it's like like Peter Kia's book and Casey Means' book. The orthopedic part is like a paragraph, a chapter, or like a half a page. And it's like, there's so much to it. And I'm biased in thinking that the musculoskeletal system is the most important one. It's the biggest organ system in our body. So it behooves us to take care of it Yeah, so working on that, I'd like to just talk more about this kind of stuff and bring it more to the forefront. Every time I'm at a conference there's always like a few orthopods who say, hey, I'm interested in that too. We should form a group. Hopefully we can sort of more formally organize as orthopedists who are interested in the metabolic side of it. So that would be cool to get that kind of more formally going.
Yeah, I know there's several orthopedic guys that sort of participate in my social media that are getting that. And I think that as much as we talk about heart and lungs and the cardiovascular system, how important it is, but you can't develop that if your chassis, if your car and your wheels are broke flat, you're not going anywhere. So you got to make sure you've got the rest of the body that can propel those things. And that's, I think, often a secondary consideration. And I realized as an orthopedic surgeon, the reason I went into orthopedics is I was like, I don't have to worry about all this chronic disease crap. Just give me a broken bone or a torn ACL and I can fix it. That was cool. But then I come to realize that all this arthritis and tendinopathy and carpal tunnel syndrome, all the stuff I was operating on in many cases was just lifestyle, chronic metabolic disease manifesting as orthopedic complications. Right. And I think that's something that is clearly not discussed enough in the because in orthopedic practice, what do you mean? I'm trained to be a surgeon. It doesn't do me any good to talk about some of those other stuff, which is interesting.
Like hook in the surgeons is saying, you might not care about it, but your outcomes will be better. Your surgical outcomes will be better if the person going into the surgery is in better condition. So if you care nothing about nothing else, then at least that will appeal to those people. So yeah, I think there's a need for it. I think at this point we can't ignore it anymore. So yeah, doing that. And then other than that, like I said, for patients who are either not local to here or who have questions that are a little more in-depth than what my normal 15-minute office visits would be, then I do some online education, essentially, if people want to talk about that stuff.
And that's outside of your group, right? That's outside of your health system, right?
Yeah, so it's technically not like medical care, it's education. It's a company called Best in Class MD. You can find me on there and just like a little visit.
And that is a frustration I saw as a physician, and I think most people, even if you want to do the right thing, I had enormous resources to get me to the operating room. I had labs, I had radiology, I had clinic facilities, I had the OR itself, which is a hugely expensive thing to run. And for me to do a lifestyle intervention, I had no resources. It just wasn't supported. And I think that's a thing that even in your own clinic, you've got to go outside and develop your own thing, which is, I think that's a real falling of the medical system. Because if you had, I suspect more people would do it if they had the resources directed to it. But again, it's how to make that cost effective and profitable. Unfortunately,
it's not incentivized.
We have to talk about it's not.
So that's unfortunate.
It's not incentivized at all. Yeah.
No. Even something like I was been pushing to get like an in-body scanner for our in-body scale that does body composition and all that. That would be such an eye opener for so many of my patients who think they're in good shape or tell me they eat healthy and tell me they exercise, and you could look at them and say, I don't know if that's true. You say, here's your body fat percentage, here's your visceral fat. To be able to, again, it's for a health system to invest in something like that. You say, okay, what's the money on the back end and all that? To me, it's just the right thing to do.
Do you, I know you mentioned that if you have the audacity to tell a patient they need to lose weight, and you get all kinds of negative reviews. And I can remember that. I remember I had a lady that came into me and she wanted like her bazillionth cortisone injection. And I said, look, you really have to address the underlying cause for this. And I'm not inclined to give you one of these injections today. She stormed out of the office, complained. I got a complaint about me not being, just handing out injections left and right. And they rescheduled with somebody else who did it. I was like, come on, this is really counterproductive in the long term. But how many, if you were to say, just looking at body composition, how much of a correlation between sort of suboptimal body composition, maybe sarcopenia, maybe too much obesity, is correlated with these orthopedic issues that you're seeing? Do you see that higher in those populations?
Almost always. Yes. Yeah. It's almost 100%. It's almost a linear relationship from what I see, or just the amount of pain that someone experiences from the same condition. There's the body composition piece of it. And then I also see it a lot with just someone's baseline activity, like someone who's like a regular exerciser. What that person is able to deal with physically is almost always way more than what you would necessarily expect sometimes.
Yes, you just got to tell people harden up. Yeah, that's something that it is quite interesting that I would see people's x-rays and you see some kind of lean old farmer that's been like busting his ass for 50, 60 years and his x-ray looks awful. and you ask about his knee pain and be like, oh yeah, it hurts a little bit.
Right.
No, it wasn't. And then you'd see someone who's just clearly never done anything. They're sedentary, obese, and their x-rays look damn near perfect with just a tiny little bit of arthritis, and they're in there howling. Oh my!
This is my everyday. Yeah. It's crazy. Sometimes people with like terrible stenosis or terrible arthritis, who are just people who've been active their whole life. And yeah, it hurts a little bit. I'm like, how are you walking? I'm like surprised. And I usually tell those people, I go, you just keep up doing what you're doing, because that's why you're able to be dysfunctional right now. And it's amazing to me that sometimes if those people end up in a different clinic, and they'll basically be told that the doctor will tell them, yeah, you have stenosis, you shouldn't exercise anymore. You shouldn't do that anymore because the stenosis you have. And like at the same time, that exercise is what's keeping that stenosis from being totally disabling. And so I go, don't listen to that advice.
I think I haven't x-rayed my whole body. I'd be scared to be honest. I'm sure I've got torn menisci and degenerative spinal. I'm sure it's in me, but it doesn't limit me in any significant way because I just get after it. I think the second I stop training regularly and hard, my quality of life will go down very quickly. I'm sure it would. So I just have to keep it up.
And like, I think also that's my attitude about it. And sometimes we'll say, I have this meniscal tear, and I'm like, okay, and you're going to stop living now? So that attitude surprises people because they feel like, me too. Yeah, me too. And then I did lift it yesterday. Those things were. There's a little bit of that kind of, okay, your life's not over. Let's keep going.
Yeah, whenever you hear somebody telling you how many bulging discs they have, I'm always like, oh, come on. It's like, I got 12 bulging discs. You're like, okay, so does half the population probably.
Right.
That's
and it's
after a certain age. And
you just got to keep moving to an extent. Be smart about it, but you got to keep moving.
Yeah, I think that's it. I think keep moving, stay strong, stop eating garbage. It's a boring but effective message that, like I said, people they want the magic, whatever. And anyway, we're out of time.
Yeah.
So anyway, we'll go ahead.
This is awesome.
And then we'll finish up.
Now, the last thing I was going to say is there's a lady that I know who goes to, she's in her 60s, 70s almost, and we were at CrossFit, and she had this kind of like weird accident. She like slipped off the pull-up bar. She was doing pull-ups. Okay, this lady was in her 70s, she's doing pull-ups, and she like slipped and she fell, and she like fell onto her back. And she was like in a lot of pain. She went to the hospital. They were like, oh my God, this 7-year-old lady fell from a height. Oh no. And they basically said, you're lucky because there was no severe damage. And because you're in such good shape, a fall like this, you really didn't have you're lucky. You didn't have a fracture. You're going to be fine. But the end result of that conversation was that the doctor said, yeah, but you shouldn't be CrossFitting. So look how dangerous it is. And I go, and that's the thing that I see often. It's you can say from that, yeah, so she fell off a pull-up bar, which I guess she wouldn't have been doing otherwise, and she hurt herself. But because she had done that regularly, this fall was essentially a non-issue. That could have killed somebody her age had she not been in such good shape. And I think that's the conclusion that should be drawn from that. Not that, that's a frustrating thing that I see a lot of medical advice coming out like that.
Yeah, and I remember when I was taking when we were taking general surgery trauma call, they would activate the trauma team if somebody fell, if they were a certain age and they fell from any sort of height, from 2 feet. They would the trauma team's got to be activated because these people, sometimes they whack their head, they have brain bleeds, they break all kinds of bones because they're made out of glass, basically. They're like dropping a fluorescent light bulb. Anyway. Yeah. All right. Amy, where can people find you on social media and anywhere else you want to share where you're located?
Yes. Social media at Amy West MD. On Instagram, on X, Best in Class MD. You can find me on there by searching my name. I'm also in amywestmd.com, coming soon. And I practice right now at Northwell Health in New York, if you're local to the area.
Okay, awesome. Thank you very much.
Awesome. Thank you.